I'm part of our police department. Police officers in America and in Brookline are trained as gun wielders. They're trained to carry a gun. And when you carry a gun, your whole mindset has to revolve around that gun. It does, and it has to. And we need those people. We need well-trained, upstanding police officers for our public safety. But we've given the gun carriers too many things to do, and we've sent them into too many situations where the gun and the gun mindset are the wrong tool. So the goal of this movement, the end goal of this movement, isn't to defund the police, for fun. That's a side effect. The goal is to find all those responsibilities that we've given to the police where a gun doesn't improve the situation, and move those responsibilities to folks who are trained to do that thing and whose training is dominated by that thing.
So again, this is the task force to reimagine police safety in Brookline, the vulnerable people and people in crisis subcommittee. The Brookline Police Department is often the first responders for people in crisis. And we were weighing out how community-based crisis intervention models might enhance what the BPD is already doing, and or potentially to replace this crisis intervention services that the BPD is doing now.
Next on the agenda, Eitan, I think this is you giving us an update on the results of the policing survey.
Okay. So just for anyone watching, just to reiterate, this survey was designed and implemented by Brian Shafter, who is a political scientist at Tufts. Just for clarification, I'll say that I am also a professor of political science at Tufts. Brian is my colleague, but I had nothing to do with this survey, except we knew it was happening because of me. So Brian was doing this survey of Medford and Somerville, the host communities of Tufts. We saw the questionnaire, realized this was an opportunity for us to get data on Brookline. So we, the task force, voted with funding from the town. We asked Professor Schaffner to run the survey in Brookline as well. Respondents were asked, which of the following police tactics and weaponry do you believe the Brookline police should be allowed to use to ensure public safety? And this is a pretty interesting table. So here, for example, 52% of respondents say that, yes, pepper spray is a tactic or weaponry that people believe the Brookline police should be allowed to use to ensure public safety. Obviously, so the range of these things is like restraint devices like handcuffs and zip ties have the highest level of support, 87%. Chokeholds have the lowest level of support. I think what's notable about this table is that Brookline residents, basically for the majority of these tools, the majority of Brookline residents do not want the police using them. The majority do not want police using firearms, beanbag munitions, canine, dog, bite and hold. The majority do not want tear gas, impact weapons, chokeholds. Most of these things do not have majority support among Brookline residents. Okay, here's a really interesting table as well. In given situations, it's possible to have either police or social service workers, such as social workers, medics, or mental health professionals respond. For each of the following situations, please indicate whether you think it would be better for the police or social service workers to respond. All right, in any kind of a physical situation, an armed individual, robbery, you have widespread support for just the police. But for most of these scenarios, intoxication, overdose, mental health crisis, homeless person, neighborly dispute, even the majority of the people in the survey, the majority think that just not even police and social service workers together, but the majority of respondents think just social service workers should be deployed in those situations. Domestic violence or abuse, more people think just the police or both. But you have a clear divergence here between situations that I think the public perceives as physically dangerous, in which the police should be responding to, and ones that are mental health situations where the majority of respondents think that just social service workers should be responding to.
That really shows that people want something different than what is offered now.
In terms of when we look at all respondents, there is broad support to limit the powers and the scope of policing in Brookline, particularly in the powers in terms of the kind of force that's used or eligible to be used. But what I see in these data is a community that really affirms the approach that our vulnerable people and people in crisis community are taking to addressing issues related to mental health, to the unhoused, and to others.
We spent an inordinate amount of time reviewing national and international peer-reviewed articles that focused on best practices serving vulnerable people and communities. We conducted 4 stakeholder interviews with different groups in Brookline, as well as to learn about programs that are happening elsewhere in the United States. Recommendation A is to consult with CAHOOTS, the crisis intervention service model that's been developed in Eugene, Oregon. We believe that law enforcement officers should not be the primary responders for people in mental health and substance use crises, that individuals experiencing crises that are not criminal in nature, violent, do not want a police response, and sometimes are triggered or traumatized by having law enforcement officers provide those services. Maybe you should just give, since we have a fair amount of people listening in, just a very brief description of what the CAHOOTS model is.
The CAHOOTS program has always maintained a staffing model of an EMT basic and a crisis worker. Our crisis workers are generally going to be an undergraduate level of experience and education. All of our calls for service that CAHOOTS responds to are facilitated through the public safety dispatch. So in Eugene and Springfield, if you call 911 or the non-emergency public safety line, you press 1 for police, 2 for fire and EMS, or 3 for CAHOOTS. By being a part of that larger system, if somebody calls 911 and says, I need police because Rush Limbaugh is in my attic and I need him out yesterday, that's not a criminal issue, right? There's a behavioral health component to this.
This will mean that the residents are safer and better served when they're dealing with mental health and substance abuse and lack of housing. And, just triggered the story that a friend of mine told me. Her mom had dementia and would do things like, if they were out of milk and she was at work, she would call the police because they were out of milk. And, just thinking, number one, what a, waste of resources. Number two, someone with a social, mental health social services background could help so much more. Number three, that was a setup for potential conflict with the police.
And by being tied into that larger system, we're not obligating officers to go out, do that initial welfare check, and then call in behavioral health teams. We are first responders. We are receiving these calls for service and going out, largely engaging, with the public and intervening in these crises without any sort of reliance on other public safety systems. We average 70 to 80 calls for service per day in our metro area of about 200,000, and we end up calling for police backup on average less than once a day.
Personally, I'm speaking as someone who has multiple family members with major mental health issues, and family members experience substance use issues. And I know what it is to have interaction with the police or think about having interaction with the police related to that, and also with many different kinds of social service providers, and what it's like when that's available and when it's not available. And when you get to the place where someone may be decompensating and acting in a way that's maybe not safe for themselves or other people, I can say for myself, I do not want someone in a uniform with all that power of the law behind them and a gun showing up as the first thing that I'm going to do. I want someone who understands the health situation that's going on and is trained in de-escalation, and who can help support my family member and myself in that immediate crisis, and to help us in the moments after it, and then what we need to do next, and to try to do it in the most person-centered, least stressful way possible. And so I don't end up with a family member who might get put in a dangerous physical position.
30 seconds.
Or I might be, because the police have that option at their disposal. And when you have that option at your disposal, you're more likely to use it, especially if you haven't really been trained in the core thing that's going on in that moment, which is essentially a medical emergency, and needing to respond to it in that way.
The response time really varies depending on the acuity of the situation and what else is going on in the community. So we operate in the same way that a patrol officer would be when they're on duty, right? You're on shift, you're driving around if you're not being dispatched to something, and then when you get dispatched to something, that's your priority. That's what you go and handle. So if we get 3 calls for service at the same time, the first one is for somebody who's stable, they're housed, they're feeling an increase in anxiety, but they're not, full-blown panic attack yet. 30 seconds after that call comes in, we get a call for somebody who's asking for help getting into shelter. They're soaking wet because they fell in the river when they got into a fight with a campmate, and it's 40 degrees and the wind is picking up and the sun is setting. And then after that, we get somebody who is in the hospital lobby and needs transfer back to detox after they've been cleared medically. The way that process is going to be triaged is we're going to go and talk to the most medically fragile person first. That's the one at risk for exposure. Then our second priority is going to be that person who went to the emergency room and needs to get back to a secure detox bed, right? We want to support that person's recovery process and really help facilitate that transfer of care. And then finally, we're going to go and talk to that individual who's housed, who's stable, and is in a relatively low acuity experience. So a lot of that work relies on effective triage with the call takers. And by using the public safety system, by having our calls routed through the public safety answering point, called PSAP, by using the PSAP, we have access to those really highly trained, highly skilled 911 and non-emergency call takers and dispatchers.
I'm a licensed clinical psychologist, and I resonate with all that Naomi Switzer just said, everything she said. And I just want to go on record as saying I agree with all of the recommendations of this subcommittee and feel that all of the recommendations should be implemented.
So from the perspective of a call taker in the dispatch center, Cahoots is just another tool that they have in their back pocket. And so as they're asking the questions to identify, is this a criminal issue? Is this an emergency? As they're gathering more information about what this caller is reporting and what it is that they're asking for, they're thinking, there's an algorithm to it, right? There's this, okay, so there's not a crime being committed. We probably don't need police. I'm hearing a lot of distress, but they're not in a medical emergency. We're not getting other people calling on this with conflicting reports of what's going on scene. There's not a weapon involved. There's no physical violence. Let's send Cahoots in. So there's that process. Our service agreement with the cities that we operate in really outlines in our scope of work the specific dispatch call types that are most commonly going to be referred to Cahoots teams. So the call taker manual that folks use when they're training in the dispatch center takes that scope of work from our service agreement and then translates that into the actual codes that they would be putting into a dispatch console. Explains that as soon as your Spidey sense says this is going to be a Cahoots call, you don't need to ask for last name and birthday, right? That there's more protection for the caller. They're able to maintain a slightly higher level of anonymity when we recognize that it's a Cahoots situation. And so call takers are trying to really triage those calls right away to see what the appropriate resource is to send out. And so it's a back and forth, and sometimes things get misidentified. And so sometimes Cahoots teams will go out on a situation that is most appropriate for police, and our training allows us to recognize those situations and then communicate effectively with dispatch. If an officer or a fire engine or a medic company ends up on a situation where Cahoots would be the most appropriate resource to respond to that crisis, because we're all part of that same communication system, that patrol officer just hops on the radio and says, hey, to the Cahoots unit that's on duty, can you come over and meet me at the park? I've got this person here who needs a new sleeping bag and a pair of shoes. Engine can say, hey, we just cleared this person medically. They need a ride to urgent care, but can't afford an ambulance bill. So can Cahoots come and do that transport for us?
And it sounds like along with the majority of those surveys, strongly agree with your overall recommendation that police should not be the primary first responders for community members in mental health crises. Police presence under these circumstances is traumatic, proven to be unnecessary, and often escalates already really difficult situations for individuals, their families, and their entire communities. And I'm also speaking from personal experience with police interfering in my own family's mental health crises in the past.
We respond to a pretty wide swath of calls that would otherwise be going to the police or to the fire department in our area. And because of how our program is designed, it costs a fraction of the amount it would to send out officers or, fire EMS to a lot of the situations that we respond to. And so in addition to, that direct and specific goal of ours of diverting folks from, police encounter or from criminal legal involvement, from, keeping them out of the hospital, we're also really able to present a real strong return on investment to our city leaders. And
one question that is coming up a fair amount, understandably, is funding.
Yeah.
How are you suggesting to cities and towns who are interested in building these programs about funding resources? Are you taking a percentage of funding from police to put toward building a new service? Are there other kind of funding resources that you suggest people look into, or how does that?
So the initial funding for the Cahoots program was a public safety fund reallocation. They chose to fund the Cahoots program instead of hiring as many officers as originally planned. That was in 88, 89. Since then, we have become our own bucket within the city fund.
I support the recommendations of the report, especially creating a new service inspired by Cahoots or other similar groups that responds to these types of crises, and removing that responsibility from the police. And I believe it would be best if funding for the police force could be reduced and that funding redirected to this service instead. And I think the select board and town meeting members should follow the clear majority of Brookline residents and institute this subcommittee's recommendations.
You should know that I'm on the town finance committee, so you'll understand where this question is coming from. But I was very interested to read the materials about Cahoots and that the community saved money over time. And I wonder if you can, is there some way that you can, like, how does that work? I can believe that it can work, absolutely,
sure.
Not at all. But I'd like to know how it did play out.
Yeah, so there are two areas where we really save our community a lot of money. Criminal legal and medical. On the medical side, we are able to divert folks from the emergency room or eliminate the ambulance that they would have needed to ride to get there and a bill that they wouldn't have been able to pay. When you look at just our diversion from EMS and the hospital system, we see a savings of around $8 to $10 million. And that's off of a program that costs about $2.5 million to run. So just on the medical side, for every dollar going to a program, $4 to $5 are coming back into the community by diverting folks from the hospital system, from EMS. On the criminal legal side, we have not been able to get the kind of partnership we would like to with local law enforcement to quantify this, but we can see that by reducing the likelihood of a police interaction for something related to addiction, mental health, poverty, that we're saving a lot of folks a night at jail, and that's $300 a pop, per night. There are fewer trespassing tickets, fewer quality of life offenses that end up going to court because that person is getting connected with Cahoots instead of being cited for camping. The Cahoots is coming in, helping them get relocated to a shelter. And so, I think I might ruffle some feathers if I try to, throw a specific number out there, but I think it would be really reasonable to say that for every dollar spent on our program, at least 5 are going back into the community. And then we also receive per member per month wraparound payment from our Medicaid provider locally. That's not a fee for service. We are not billing insurance for any of the work that Cahoots does, but because we are saving our Medicaid providers so much money every year in the form of diversions from the ER and fewer, high acuity visits, we're able to do a lot of prevention. We're able to help address a lot of social determinants of health. And to that respect, in order to recognize that contribution and ultimately the cost savings that we provide to Medicaid in our community, we get a monthly wraparound payment as well.
I just want to reiterate the support I have for this committee and the amazing work you've been doing, and want to be another person in the community who voices that support. And also that when I was younger, I was always really scared to call the police or ask for help when there were mental health crises because I was scared of cops coming to my house. And I really wish this was in place so that that didn't have to happen. This was not only in Brookline. There have been scenarios throughout my life where I've been just too scared to call for loved ones. And I hope that this is implemented so that, I won't be scared in the future and other people won't be scared to the same extent because there won't be people who are carrying weapons.
I think it speaks well that the model has been in place for so long where you are, and then you have the benefit of all the years where it's been in place there, as well as sort of seeing other communities adapt their own model of this.
Time and time again, we hear that officers don't sign up, with a police force to be a mental health clinician. They don't sign up because they want to do case management and social work all day. And yet that's what a lot of, calls they're being sent to are obligating them to, that's the role they're obligated to assume. When we bring in a program like Cahoots, we're taking those things off their plate. And there's potential for this to, even really kind of act as a force multiplier where if you don't have officers responding to all these mental health crises, to waking up folks who are just trying to sleep and meet basic human needs in a park because they don't have the privilege of 4 walls and a roof, officers are inherently going to be more free to address crime, to do those Dewey traffic stops or, chase the bank robbers.
Like these all sound like great recommendations, like especially Cahoots, like at the fraction of the cost, you get more effective services. I don't know about you, but I can't remember the last time I had a therapist who carried a weapon with them at all times and was trained to kill people. So I don't think that we should treat the homeless or poor the same way. But in terms of like the process for getting this passed, because it seems like 80% of people, 60 to 80% of people are for this. This is like widely popular. It would be a shame if this didn't pass. what can you speak to any influences? Like, does the BPD have like a police union which lobbies our government? Like, why don't we already have this?